Hello, everyone, and welcome to today's webinar, Empowering Perspectives, Women Leading the Way in the Diabetes Community. I'm Rachel Reeve, Executive Director of Research and Science at Diabetes Canada. Before we begin, I want to take a moment to acknowledge the importance of the lands which we each call home. I'm coming to you from the traditional territory of the Haudenosaunee and Anishinaabe peoples. From coast to coast to coast, we acknowledge the ancestral and unceded territory of the Inuit, Métis, and First Nations people who call this land home. We do this to reaffirm our commitment and responsibility to improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. A few housekeeping items before I introduce you to our panelists. This meeting will be recorded. We will begin by getting to know our incredible panel, who all come from diverse backgrounds and roles in the diabetes community. After that, everything will be live and interactive. Both the Q&A and chat function are open in Zoom, so please enter any questions you may have, and I will ask them of our panelists on your behalf. The chat is visible to all participants, while the Q&A function located at the bottom of your screen is only visible to myself and our panelists. It is with great pleasure that I introduce you to an exceptional all-women panel today. I am joined by two Diabetes Canada funded researchers, Dr. Jane Yardley and Dr. Diana Sharafali, one of DCAMP's physicians, a pediatric endocrinologist, Dr. Sanjutka Basik, Jillian Rutherford, who lives with diabetes and was a research partner, bringing her lived experience, perspectives, and expertise to Dr. Jane Yardley's research study, and Lindsay Mitcoli, who will be sharing with us her journey with diabetes and role with our partner organization, Diabetes Action Canada, which is a Canadian Institutes for Health Research support unit for their strategy for patient-oriented research. Each of these remarkable women brings forth her own unique journey and insights, yet they share a common mission to contribute towards a more inclusive world free from the effects of diabetes. We extend our deepest gratitude to our esteemed panelists for joining us today. And to our audience, we sincerely appreciate your presence. It is through the collective efforts of your dedicated individuals and partners like yourselves that Diabetes Canada is able to advance its crucial mission. Your support enables us to fund vital research initiatives, offer invaluable resources to our community, and persist in our unwavering commitment to end diabetes. Thank you for your support. To start us off, here is Jillian Rutherford.
Hello, my name is Jillian Rutherford and I live in Edmonton, and I first was diagnosed with diabetes in May of 1980 when I was 17 years old. So that was a long time ago, 44 years, and I'll let you do the math on how old that makes me, but I can say that diabetes has affected probably every decision in my life and every day of my life. It's something that never goes away. It's always on my mind. And I was really lucky. My mother was a nurse, and she was able to help me as a young adult understand what was going to be required of me to take care of myself. So I really had that advantage. And I've tried all different kinds of ways of taking care of diabetes over the years. You know, started out just taking a little tiny bit of insulin, and at that time you had to pee in a cup in order to tell whether you were spilling sugar in your urine. So technology has really improved since then. I've used multiple injections. I've had several different insulin pumps. I got a continuous glucose monitor a couple of years ago, which really helps with daily management. And in November, I started looping, which is a really interesting innovation that has taken a lot for me to learn about in terms of managing the technology and so on. But even with all of these assists, I guess, technical assists, it's still a challenge managing exercise, which is something that's really important to me. I thought I had already drawn my short cards, but you know, being diabetic, but when I was 43, I developed breast cancer, and that was really challenging going through that treatment and also managing my diabetes at the same time. But there was a real silver lining because I joined a dragon boat team for breast cancer survivors, and I've been doing that ever since. So I work out 3 times a week with a group of really motivated ladies who, give me a reason to show up. We practice together in the gym, on the water, once it's not frozen anymore. And we compete in festivals all around Canada and even the world. I've been to Florence, Italy, and paddled on the Arno with Breast Friends, my team. So anyway, I heard about Jane Yardley's research at the University of Alberta because I work at the university, and decided I'd like to volunteer. It's something that's really important to me to not only better understand my own diabetes and how to manage things for myself, but hopefully to make life better for people who are just finding out today that they have to deal with diabetes throughout their life. It's so important to be active, whether you're young or old, but certainly in terms of managing, complications that might come from diabetes and just living well as an aging person. So I participated in a couple of Jane's studies. I also am participating in a program at the U of A where they pair people with chronic illness with young med students who are learning how to be doctors so that they can understand what it's like to live with a chronic illness. So I'm really motivated to help if I can, and to learn more today during this panel. So thanks for having me.
Hi, I'm Dr. Jane Yardley of the University of Montreal and the Montreal Clinical Research Institute. I'm proud to be supported by Diabetes Canada for a project related to exercise in menopause or after menopause in people living with type 1 diabetes. Today I'm going to present a little bit of the background behind why we're doing this project. There are lots of barriers to being active when living with type 1 diabetes. Today I'm going to present a few of those to you. I'm also going to talk a little bit about exercise-related dysglycemia and why exercise is so complicated for people who have type 1 diabetes. And finally, I'm going to talk a bit about sex and gender-related barriers to exercise in those living with type 1 diabetes, and in particular, those who have gone through menopause. People with type 1 diabetes should exercise for various reasons, but we do know that we have very strong data to show that one of those is living longer. We also know that those who are more active will have a lower risk of heart disease. They'll develop fewer diabetes-related complications when it comes to their kidneys, their eyes, their nerves. They'll maintain a healthier body weight. They'll have more lean body mass and bone mineral density, and this is an important point that I'll come back to later in the presentation. We also know that people who are active have a better self-rated quality of life. They generally seem to be happier. In my mind, this is a magic treatment that everyone should have access to. Unfortunately, there are a lot of reasons why people don't exercise. In the general population and those without diabetes, those include not having enough time, money, or knowledge, not getting the results that they want fast enough, or a lack of enjoyment. They just don't like being active. For people with type 1 diabetes, we know from a 2008 study that fear of hypoglycemia, so low blood glucose levels, and fear of losing control over blood glucose levels are two very large diabetes-related barriers to being physically active. When it comes to type 1 diabetes, aerobic exercise is very difficult to manage. We know that low to moderate intensity exercise causes fairly large drops in blood glucose levels and is associated with a higher risk of hypoglycemia during exercise. Most of this is due to beginning those exercise sessions with higher than desired levels of insulin. And the reason that this is really tricky is because synthetic insulin, which is required to treat type 1 diabetes, does not behave the same way as naturally produced insulin. On this graph on the right, we see the green peak to the left of the graph. That is naturally produced insulin. It has its onset and its peak very quickly so that it can help store glucose, and then it is out of the system very quickly afterwards. The other peaks that we see, even the fastest fast-acting insulin, synthetic insulin, is going to take several hours to clear the system. And for this reason, exercise usually starts with higher than wanted insulin levels, which can be problematic. Where keeping the balance is concerned, when there's an increase in glucose, the pancreas would normally respond by increasing insulin. And then this helps the body cells store that glucose for later use. With type 1 diabetes, this doesn't happen automatically because the cells in the pancreas that create insulin are destroyed. So the insulin that gets put into the body by pump or by injection is what's used to try and bring those glucose levels back down. This is a bit more of an art than it is a science, and no 2 days will be the same. So we know that blood glucose levels are going to be a little bit more variable when there's synthetic insulin being used. On the opposite side, when there's a decrease in glucose associated with physical activity or exercise, the pancreas's natural response is to decrease the amount of insulin being released, which means that insulin would normally decrease very quickly in circulation. This would allow the release of glucagon, also from the pancreas. But we know that with type 1 diabetes, and in particular with long-standing type 1 diabetes, that this glucagon response to exercise is often impaired. As glucagon's role is to be active in the liver to allow some of the stored glucose into circulation to maintain blood glucose levels during exercise, not having access to this glucagon can cause a lot of problems and oftentimes causes a big drop in glucose during exercise. If we look at intense exercise, it has slightly different effects, but we also know that it has very mixed effects. The reason why it's different is that epinephrine or adrenaline will actually access the liver and dump some of that glucose into circulation to help maintain blood glucose levels during intense activity. We do see, however, that it's not a very consistent response. This graph to the left shows participants from my lab having done a high-intensity workout, essentially a 10-minute test of fitness where they go as hard as they can until they are exhausted. And the dotted line down the middle is a zero increase or decrease, and no change in glucose. And you can see that there are just as many people to the right as there are to the left, with changes in glucose being as big as an increase in 3 millimoles per liter or a decrease in 3 millimoles per liter. We also know that if exercise is performed in a fasted state, that is going to have a different response. This plot that we see to the right is a meta-analysis of high-intensity interval exercise. The line down the middle of the right-hand plot is a no-change line. And the diamond right at the bottom shows that, in general, there is a decrease in blood glucose with high-intensity intermittent exercise or interval exercise. But the one right above it shows only the fasted exercise studies where we see an increase in glucose. And the one above that, the first diamond, shows that when these exercise sessions are performed in the fed state, there tends to be a decrease in exercise. If you're scratching your head right now, you're not alone. Exercise with type 1 diabetes is very complicated. And unfortunately, it gets even more complicated if you are female. This is where I'm going to discuss a little bit about sex, gender, exercise, physical activity, and type 1 diabetes. We know that women with type 1 diabetes are less active than men with type 1 diabetes. This isn't very surprising, as women without type 1 diabetes are actually less active than men without type 1 diabetes. But we have to ask whether or not there are more barriers to exercise for women with type 1 diabetes. We know that fear of hypoglycemia and fear of loss of control of diabetes management are major barriers to exercise in people with type 1 diabetes. But we've also seen recently that women report more level 2 hypoglycemia than men and report more persistent fatigue as a result. Exercise guidelines for carbohydrate intake and insulin adjustment were also all developed in studies that involved only young, fit males or mostly young, fit males. There's generally a lack of studies examining exercise responses in females of any age. And when I have female participants come into my lab and I mention this to them, I usually get a look similar to this. Lately, there's been more attention on trying to report female characteristics better and also trying to include more female participants in exercise-related diabetes research. The little that we know about sex-related differences in blood glucose responses come from this single secondary analysis of previously collected data. We collected these data in my lab during a resistance exercise session, and here we can see that the male participants tend to have a bigger decrease in blood glucose during exercise than the female participants. Because this was a secondary analysis and was not designed to answer this question, we're not really sure why we're seeing this response. Could it be that it's a true sex-related response and that females tend to use their fuel differently during exercise? Or is it because the males had more muscle and more body composition, and that body composition changed the glucose response? Is it because they lifted more weight because they were on the whole stronger than our female participants? Or was it a question of behaviors? Was it that our female participants were better at adjusting their insulin or more careful at adjusting their insulin prior to exercise? Being female with type 1 diabetes has a big impact on health, and we know that reproductive health is one of the things that's affected. We see menstrual dysfunction fairly commonly in females with type 1 diabetes. We see higher rates of infrequent menstrual periods, longer cycle length, greater infertility, more polycystic ovarian syndrome. Hyperglycemia in the last week of the menstrual cycle is also quite common, and that actually changes the risk of hypoglycemia during exercise, as we see female participants with more insulin in circulation trying to control that hyperglycemia during that last week of the menstrual cycle. Some studies are also showing more frequent early menopause, and this is important because menopause and aging in type 1 diabetes have a synergistic negative effect. What we know about aging in type 1 diabetes and the menopause transition is that compared to females without type 1 diabetes, those with type 1 diabetes seem to have a higher risk of fractures, and that would be as a result of decreased either bone quality or bone density. They seem to lose muscle mass at a faster rate and muscle strength at a faster rate, and we see a disproportionate increase in the risk of cardiovascular disease. Taken together, this gives an increased risk of frailty in aging with type 1 diabetes, in particular in females. Fortunately, we know that exercise, and in particular resistance exercise, can help, if not reverse, at least slow down these processes. Hence the reason why we are trying to ascertain the safety of exercise in this population. We can't assume that all of our insulin recommendations and carbohydrate recommendations are going to be similar for females with type 1 diabetes. We know that after the menopause transition, there's a decrease in total insulin per kilogram and total basal insulin, while at the same time, bolus insulin seems to remain the same. Adjustments to overall insulin administration become necessary through this menopause transition. And this probably means that we're going to have to also adjust insulin differently for exercise. But right now, we just don't have those data. We know that there are possible sex-related differences in blood glucose responses to exercise. We know that there are possible age-related differences in blood glucose responses to exercise. My current Diabetes Canada funded study is looking at how blood glucose responses to aerobic and resistance exercise compare to a day without exercise, essentially to figure out the impact on blood glucose levels and to ascertain whether or not our current recommendations are appropriate for this population. The hope is that we'll be able to either confirm that the guidelines are appropriate, or if not, refine the guidelines so that they can be tailored in an age and sex-specific way. Later, we're also going to use these data to design a training program for an intervention study to see if we can use exercise to prevent or delay the complications associated with aging and diabetes. I'd like to thank Diabetes Canada for the opportunity to present a little bit of my background and for the opportunity to perform this research.
Hi folks, my name is Lindsay McCauley. I live with diabetes and I also work in diabetes, and I'd love to tell you a little bit more about my story today. So I like to tell everybody that living with diabetes might be the least interesting thing about me. I'm also a daughter, a sister, a wife, a friend, and there's a lot to my story that happens before I even got diagnosed with diabetes. So I'll take you back to when I was 6 years old. I moved to Canada with my family. From a small country called Albania. So when I was 6 and we moved to Canada, I had never spoken a word of English before. I had never even seen snow. We quickly adapted, and that part of my life is a really big part of my story because coming to Canada meant opening up a world of possibilities for my future. And part of that included the ability to learn new languages like English and French, but also to pursue the academic and professional pursuits that I dreamt of and that I was passionate about in a way that my ancestors didn't get to pursue. For me, that meant pursuing science and healthcare. I did an undergrad in biopharmaceutical sciences, and I also did a master's degree in sustainability in healthcare. I was really curious about how I could leverage science to improve people's health and be of service to my communities to make their lives and their experiences in the healthcare system a little bit better each day. I did all of this without living with diabetes. I actually lived 25 years of my life without living with diabetes. And at 25, getting my diagnosis came as a really big shock. So ironically, I had studied diabetes in my classes and, of course, worked with folks that had lived experience of diabetes, but I have no family history. I have nobody close to me at that time that lived with type 1 diabetes. So it was a big shock. A big part of how I adjusted was leveraging resources from Diabetes Canada and meeting folks with lived experience of type 1 and understanding that, I could be normal again too, because I saw people living really fruitful and full lives with type 1. A big part of my grieving process of my old life and trying to adjust to this new reality was connecting with community, but also seeking opportunities to give back to community. It really did feel like the diabetes community helped pull me out when I felt like I was drowning when I was initially diagnosed, and I wanted to give back to all the people that helped me so much. I started volunteering with an organization, Diabetes Action Canada, which is one of the partner organizations from Diabetes Canada, and a lot of their work is funded by DC. And I started volunteering my time as a patient partner. So essentially, I wanted to participate in research studies, bring my lived experience of type 1, but also bring my academic backgrounds and my professional background, and hopefully make diabetes research a little bit better and give back to the research community and the diabetes community at large. My story started as a patient partner, but today I'm also the lead of patient engagement at Diabetes Action Canada, and I have the privilege of working not only with other patient partners, but also with folks at Diabetes Canada and other researchers like the other people on this call to hopefully make the lives of people with diabetes better day by day. I often tell people that being the lead of patient engagement is being like a bridge builder between several different islands in the diabetes ecosystem. And I like to explain it in a framework that I like to call the 4L framework. So I'm speaking to you today as somebody with lived experience of diabetes. So that's the first L. I have the diagnosis on my medical chart. I'm the one that takes insulin every single day. Sometimes I get it right, often I get it wrong, but I'm the one that lives with it every single day. I also have other people in my life, people with loved experience, so that's the second L, that support me in my diabetes journey. They might not live with it, but they know what it's like to try to help somebody that they love live with it every day. They know what it's like to watch somebody that they love struggle with diabetes sometimes. And then I have the privilege of working with folks with learned experience of diabetes as well. So that's the third L. Learned experience looks like researchers, for example, who have academic expertise in topics that I know a little bit about through them, but they're experts in islet cell biology and mental health topics and much, much more. And then the fourth L is labored experience of diabetes. So people that work day in and day out in this ecosystem in organizations like Diabetes Canada, or maybe nurse educators that we see when we don't know how to carb count for something. So my job is to try to connect folks with lived experience, loved experience, labored and learned experience of diabetes, build bridges between these four islands to hopefully make diabetes research better every single day, and ultimately by creating better research to inform better policy. The goal is to make lives better for those of us with diabetes so that we struggle a little bit less, but also that we're able to live fulfilling lives and do what we want to do. I know that for me, life does look different now post-diabetes, but it's still fulfilling. I still play sports like I used to, and I cook and I travel and I spend time with my loved ones. It looks a little bit different than it did before, but I'm internally grateful for all the researchers and the folks that work at organizations like Diabetes Canada that have enabled the progress that we've made that allow me to live this fulfilling life. And I just want to make sure that I could do whatever I can to make it easier for one more Lindsay out there or one more person that lives with someone that has diabetes so that everyone's lives are a little bit better day by day and they're able to live fulfilling and happy and fruitful lives despite having a diabetes diagnosis. Thank you so much for listening to my story today.
Well, thank you to Diabetes Canada for the opportunity today to present about diabetes remission in primary care. It's a 3-year study that I'm very excited to present on behalf of the Remit Prime team. Thank you to Diabetes Canada for funding this initiative, and thank you to our partners at the Population Health Research Institute, McMaster University, and the Centre for Family Medicine, a family health team in Kitchener, Ontario. So what do we know about type 2 diabetes management? Is it working? At this point, it's safe to say that type 2 diabetes management is a stepwise approach in which at every step, we're essentially reacting to someone failing to achieve a goal. And unfortunately, this may create a lot of shame and stigma about lifestyle modification, eating healthier, modifying how people eat. Are they getting active? Are they losing weight goals? So unfortunately, this can create some shame and stigma about not being able to fulfill or meet behavior modification goals. As people move through the stepwise approach, it can get very complex. One pill suddenly adds to another pill, 3 pills, maybe even 4 different types of medications, including injectables. Sometimes insulin is also added. So the complexity of the pharmacotherapy or the medical management can get quite complex. Type 2 diabetes management, as we currently know it, is also very costly and burdensome to the individual, with the cost of testing supplies, additional supplies such as needle tips, maybe supplies that are related to screening or the treatment of complications, and then of course costly to our healthcare system for the prevention, screening, and treatment of complications such as eye, nerve damage, kidney damage, and of course bigger vessel damage like heart attack. So maybe it's an opportunity to rethink, how are we treating type 2 diabetes? Is it actually working? And I would suppose that many of you, just from hearing this, would assume that maybe there's another way or a better way or even a different way. And along comes diabetes remission. So diabetes remission flips the paradigm of treating to failure to looking at an approach of, can we make diabetes go away, even if it is for a short period of time. Very briefly, we've learned a lot about diabetes remission from bariatric surgery. In various studies of various types of approaches to bariatric surgery, we know that diabetes remission occurs in 60% of people at 1 year. In other words, if they've had bariatric surgery and they had type 2 diabetes going into the surgery, at 1 year, 60% of people no longer have type 2 diabetes. Another form of diabetes remission comes in the aspect of nutrition-based interventions. And to date, we've heard a lot about very low calorie diets. And these are diets that are probably about anywhere from 800 to 1,000 calories a day, very extreme. In a lot of this research, we found that 46% of folks are able to go into remission at 1 year. Obviously, both of these strategies are very complex, very severe in their nature. Not everyone wants to go for surgery if they don't need it, and not everyone can sustain a very low calorie diet. So, what else is there in terms of diabetes remission interventions? For the last decade, I've had the pleasure of working with a phenomenal team based out of McMaster University and multiple sites across Canada looking at diabetes remission. And this is the remission evaluation of metabolic interventions in type 2 diabetes. Very briefly, what we've tried to do with the REMIT approach is to use diet, and very loosely we're calling this diet, but this may mean not so much going on very low calorie diets, but changing how people eat. Sometimes it may be the quantity, sometimes it might be the consistency of what they're eating, or the quality, more fiber, lower fat, something like that. We also look at metabolic parameters. So for example, can we be improving people's metabolic state, their blood pressure, their cholesterol targets? How physically active are they? And then we also add pharmacotherapy. So to the right of your slide, you'll see that there's multiple REMIT studies that have looked at trying to aim for remission with different combinations of medications, so different pharmacotherapies. The one thing we have not tested is surgery, and to date, the evidence is very compelling for surgery. However, it's not easily translatable or implemented in primary care. So our studies have shown that we can achieve remission anywhere from 68% upwards to 75%, depending on the combination of medication. But at the core of the remission approach that's focused in REMIT is a multimodal intervention. It includes nutrition, physical activity counseling with a health coach. It includes pharmacotherapy that's targeting diabetes and other metabolic parameters to ultimately induce diabetes remission. So the REMIT Prime study looks at this from a slightly different angle. We have compelling evidence that this works with different combinations of medications. What we don't know is this something that we can do and implement in routine primary care. Primary care is the cornerstone and foundation of our healthcare system, and primary care is where most folks go to seek and gather diabetes education, but also where most of diabetes management occurs. So our study is intending to implement and evaluate the remission protocol that we have tested is evidence-based and safe, but we are now going to try this in routine primary care. So our intervention is a 16-week intensive intervention that includes frequent visits and health coaching. Again, these are foundational principles to any metabolic or behavioral change interventions. It includes diet, and that's very much tailored to the individual. So some folks might appreciate intermittent fasting. Some folks like a high fiber diet or low glycemic index diet. Some folks may want to focus more on physical activity and what that might look like for them. At the end of the day, the broad goal is weight loss of about 5% or less. And then we always start with the cornerstone pharmacotherapy medications. Metformin is routinely and regularly available and very safe to use. There is a little bit of basal insulin, which is a little bit counterintuitive, but you can think of the basal insulin as something to protect and rest the pancreas while we're trying to metabolically stimulate everything else. And then we add other medications, and the other medications are tailored based on the needs of patient individuals, but also what's available through insurance coverage or what primary care providers feel comfortable using. So it's a combination of various pharmacotherapy medications along with health coaching and metabolic nutrition and physical intervention changes. So we're proposing to follow 80 participants. They will be randomized half to usual care or usual standardized type 2 diabetes approach. The other half will get the 16-week intensive intervention. And we're going to follow them for the 16 weeks. At 16 weeks, we stop all medications to see if they indeed go into what we consider to be remission. So that's an A1C, glycated hemoglobin, that 3-month average. If it's below 6.5% at 16 weeks, we stop all glycemic lowering drugs, and then we follow them along carefully and slowly. The coaching check-in calls still occur every 12 weeks, but we're going to follow folks for 1 full year, checking in on them at 16 weeks, 28 weeks, 40 weeks, 52 weeks, and 1 year after the intervention. Now, the other interesting part in all of this is not only are we looking at the effectiveness of the trial, but we are also looking at how did we set this up in primary care, and that's the implementation evaluation. So a little bit more about the evaluation then is we have the timeline. The top bar that you're looking at is the implementation of the effectiveness study, the clinical trial. What is the impact on the metabolic parameters? But you can see with the second bar, we are actually following not only how did we set it up, We're also assessing what worked, what are the levers, what are those great opportunities that we have in primary care? What are some of the challenges? What are some of the things that we didn't anticipate might be a barrier to offering primary care remission interventions? And then at the end of the study, closer to the right-hand side, we're going to be assessing what is the impact of this study on healthcare providers, and ultimately, what is the impact on patient experiences? Did they like this? Would they encourage the adoption of this in broader primary care settings? In other words, would they recommend this to another colleague or friend? So with our study plan, and we're so grateful for funding from Diabetes Canada, we feel that we really have an opportunity to rethink how we manage type 2 diabetes management in primary care. Our study's not only going to look at the effectiveness, but really truly, how are we doing this in primary care? Our hope is to provide a toolkit, and through the toolkit, we're hoping to ultimately build capacity and bring people along this journey of rethinking type 2 diabetes management care as we know it. Thanks again to Diabetes Canada and all of our partners and collaborators.
Hi there, I'm Dr. Sanjukta Basak, and I've been asked by Diabetes Canada to speak to you a little bit about my experience working with this wonderful organization. I have a lived experience of having diabetes during my pregnancies. I have been a caregiver for multiple family members with type 2 diabetes. So professionally, I'm a pediatric endocrinologist. I've worked and trained in Ontario, and currently I'm an academic staff here at BC Children's Hospital and a clinical assistant professor at UBC. I get to wear many hats in my job, which I love the variety of what I do. I work in research in health equity and in particularly around stigma in the care of youth with diabetes and obesity. I am the medical lead for the type 2 diabetes program here, and I also run a lot of QI projects or quality improvement projects around our insulin pump program. So I want to talk to you about, though, the favorite hat I get to wear and the best thing I get to do every year, which is come to diabetes camp as a camp doctor. I've been starting to go there since I was a doctor in training as a resident, and I've been going there for about 11 years now. In clinic, you know, at the end of the day, it's a medical appointment, and I get the honor of seeing families and their children with a team of doctors and nurses, dietitians and social workers. But really, at the end of the day, our focus is about their health. We're focusing on medications, their insulin dose adjustments, blood work, thinking about risk of complications, and what's happening at home and school. On camp is really where I get to see kids thrive. I get to see joy. I get to see them try new things. And I have seen camp really help kids and families through difficult times. I can see kids getting a sigh and getting a breath of the freedom of being able to enjoy an overnight camp experience. And I see the parents also similarly having that same sigh of freedom from worry, knowing their kids are safe and being able to enjoy an amazing time in their summer. I always go to camp because I get to learn so much from the people that are there and from the kids themselves. I come back to clinic recharged and rejuvenated with so many new things that I've learned. And I go to camp really not because of the place, but because of the people. Thanks so much for listening, and it's been a pleasure to share my story with you today.
I hope you enjoyed those videos as much as I did. It's so great to hear from the researchers and to hear from a DCAMS physician and the people living with diabetes, whether they're who both also have roles in the diabetes research community, participating as research partners. That was a wealth of information, and thank you so much to the panelists for sharing your contributions to the diabetes community. That was wonderful. To the participants in today's webinar, we have the chat and the Q&A open, so please feel free to type away and I'll ask questions on your behalf to our panelists. And I do have a couple of questions that came in through the videos. So we'll go ahead and get started. And my first question, and it's a couple here that'll kind of roll together, but for Diana, I was wondering if you could speak a little bit to how the term remission was selected to describe this and what the definition of remission is.
Hi, thanks for that question. So what's really interesting is Diabetes Canada came up with a definition based on a consensus guideline process. And the American Diabetes Association and the European Association for the Study of Diabetes has come up with a slightly different variation. At the end of the day, the sort of putative kind of in principle approach is that after any sort of remission intervention, when medication is stopped, the A1C is 6.5% or less. But I think, at the end of the day, we are working towards the sort of principled approach of when medications are stopped, are they less than 6.5% for 3 months? And then, of course, when we study all of this moving forward, we're looking to see how long can they stay in remission. I think the other interesting thing is there's the definition of remission, but the length at which people stay in remission is something else that we're learning along the way.
Thank you for that. And if I can follow up, and I'll ask one more question about definitions. You spoke about intermittent fasting, and there was a question here about intermittent fasting being linked to cardiovascular risk. And I wonder if you could comment on that, as well as describe within the study that you're working on, funded by Diabetes Canada, what the definition of intermittent fasting is there.
Right. So as part of our person-centered approach, we are not necessarily advocating for one pattern of eating. We have some of our patient partners in our remission projects and studies to date that are big fans of intermittent fasting. So what we encourage folks to do is always consult with a registered dietitian to find the right pattern that works for them. So for some folks, based on their context, their work environment, et cetera, fasting for about 12 to 14 hours might work for them. And that fasting might mean having some fluids, clear fluids, coffee without any milk, sugar, etc. But then they break their fast with a period of eating various meals throughout sort of a condensed period of time. So we're not certainly advocating for intermittent fasting. That's something that they should discuss with a registered dietitian. I think the key thing is to find something that works for the individual. That's the key thing. To address the comment about the vascular, I forget how the question was worded, but it was the association of cardiovascular events and intermittent fasting. I'm aware of that. That was sort of late breaking news that was highlighted at a research conference. The key thing with that finding is that was based on observational data, sort of natural occurring data in a particular large cohort database. So following people sort of organically as they live their lives, put your hand up if you do intermittent fasting, and then they look at associations. And because we can't control for some of those other factors like smoking, stress, ingestion of other types of foods that may put people at greater risk for cardiovascular disease, sort of known behavioral, environment, societal. We can't control for that. So all we're seeing is the link or an association or connection. However, all of the randomized controlled trials that are testing intermittent fasting versus usual dietary patterns are not giving us that signal. So I think that's definitely one of those instances where we need to read the research a little bit more carefully.
Thank you for that, and for explaining the importance there of taking that information and how we take conclusions from it. And all that information about remission was really wonderful to hear about. I have a question here for either of our two people joining with their lived experience. So either for Jillian or for Lindsay. And somebody here would love to understand from your perspective, I think what surprised you most about getting involved in research from the patient perspective, and what have you enjoyed the most?
It's Jillian here. I will say one of the things I enjoyed most was meeting Dr. Yardley's extremely vibrant and interested and smart students who helped her with the research. So there were master's and PhD students involved in hooking me up to machines and coaching me through workouts. And the focus of the study I did was on exercise. And at least one of the students was living with diabetes himself. And so I was very impressed that he would live with diabetes and also work in diabetes like Lindsay. Because frankly, some days I'm really sick of diabetes and I don't want to think about it or talk about it anymore. But I had an overwhelmingly positive experience. It took some time out of my day, for sure. I had to, eat the same meals over certain periods of time and report on that, and my blood sugars, which some days I wasn't feeling so good about telling everybody how bad I did. But, it was worth it because I could see the greater goal, and these students were so supportive and positive along with Dr. Yardley.
I'd love to add on to what Jillian just shared and say that for me, having had a science background and a healthcare professional background before getting diabetes, there's a certain level of hierarchy that's instilled in you in your training. And you often think that from a participant standpoint, the only way that people with lived experience can give is by being participants in a clinical trial. And I think that first, I have tremendous amounts of respect and admiration and gratitude for people that do that, full stop. But starting to work in diabetes and participate in research, it really challenged my assumptions about hierarchy and the ways that people can give. So you can give by putting your hand up to follow a regimen, or you can give in a focus group or a survey or helping co-design a study, or sometimes even in conversations about what questions do you want answered as a person with diabetes. I will say though that Jillian's answer also makes me think about the value and the pricelessness about working with other TWOFers. There's a lot of us with diabetes who work in diabetes, and there's just the level of normalcy that you feel working in the field with folks that also live with it is incredible and is something that I'm very grateful to have the opportunity to do.
Thank you for those answers. My next question is for San, and we saw a comment in the chat about how much they love you at camp. So I thought I'd share that with the audience. It came directly to the panelists. But I wanted to ask you, what led you to be involved at camps, and what's your biggest takeaway from being a physician at DCamps?
So I had the opportunity of joining as part of my endocrinology rotation, we have the opportunity in the summer to come up for a week. And I never had the opportunity to go to camp as a kid, and I didn't realize how much I would have loved being there as a kid myself. But it's a great learning opportunity to also be there with children and be able to manage their diabetes, either for them if they're very young or with them as they're a little bit older. You get to see changes that you're making in settings of different diets and different activity regimens, and see what the impact of that is. So it's kind of how I started off, and then the opportunity came every year. And when I graduated and became staff, I jumped at the chance to come back. I still do come to Ontario to participate in Camp Huronda. I think for me, what it means is to be able to see diabetes in real life. And while I don't have a lived experience of type 1 diabetes, I learn a lot, and I'm very curious, and I come with an open mind. And I learn from families in terms of what works for their child. I think we can all agree that no two people with diabetes are the same. So it's that experience that I get to share. You learn tips and tricks as well from the nurses that also have lived diabetes and come to camp, and different nurse educators from different parts of the province and the country. And you also get the opportunity to hear from children, like what works for them and what doesn't. Things come out in camp as well. That doesn't always come out in clinic appointments around what's working for them and what's not. And it gives us an opportunity to support local diabetes education teams and their clinicians as well, in terms of reporting back into what happened at camp or what works well. It also gives an opportunity for kids to see other different technologies and try them out potentially at camp, or see other kids manage diabetes in other ways. We also see kids from quite remote parts of Canada come to camp and maybe meet a child who has diabetes for the first time other than themselves. So it's pretty exciting to see that network and that community kind of develop amongst the youth themselves. And many of them come back year after year. So you see that relationship blossom. Being in my 11th year now, I'm kind of starting to see some of them graduate and become counselors. So it's exciting to see how the community just grows in different ways.
Thank you for that. We have a question here for Jane, and we'd love to hear about what led you into this area of research. You spoke about type 1 diabetes and exercise, and then in women, and then women over the age of menopause. And so how did you land on that type of research question?
It actually started because I spent a lot of time in the lab. I was working at a faculty where it was mostly undergraduate students, and so they couldn't be in the labs by themselves. I would be in there testing the participants with them. And we would be trying to schedule people for the next week or two. And it happened more than once that one of my female participants would say, yeah, sure, next week would be, oh, no, not next week. I'm getting my period next week. And that just really screws things up. And so I started to wonder, is that a thing? And when I went to look at the literature, there just wasn't a lot out there on the menstrual cycle. So I started doing a bit of digging and realizing that, well, yeah, there's different blood glucose levels throughout the month, and that's going to affect things during exercise, but nobody's actually looked at that before. And then I started reading a lot more on how female hormones can affect metabolism, and how much changes just throughout menopause, the impact that it has on the female body, and that combination of type 1 diabetes and menopause. And I keep thinking, okay, well, if we're looking at muscle mass and bone density, like obviously exercise has got to be part of that picture for aging in a healthy way with type 1 diabetes. But then if you look at all the studies that are out there that we use to give people advice on managing blood glucose, they're all done in young, fit, mostly male participants. So I think we just have so many gaps in the data around women. Around females, I should say, because I've got to get the sex and gender language straight. I know there are some specialists on the call on this one. And there aren't a lot of women researchers in this field, in exercise and type 1 diabetes. So I feel like it's something that I really need to do. And I'm trying to encourage a lot of other women researchers to come along with me on this ride, both in type 1 diabetes and type 2 diabetes in the exercise field. Because, traditionally it's female participants have been overlooked in research, and it's time to start changing that.
They have. It's really interesting that you are going one level deeper too, with the increasing lens on how important it is to separate out the participants in research and how broadly you can make conclusions. So thank you. I have a question here, I think for anyone on the panel who wants to speak to it, but I'd love to hear from you. What are common misconceptions people have regarding diabetes? And then maybe what can we do to combat those misconceptions and communicate more effectively? And if it's easier to start with the first half of that question, from your perspective, what are some common misconceptions that you've encountered about living with diabetes or diabetes research in general?
Maybe I'll go. And I think just type 2 diabetes in general, I think there's a lot of shame and stigma associated with someone causing it. They didn't do enough of something, they did too much of something. So I think the biggest misconception is that this is not an individual lived experience. This is, a multifactorial approach. So that's probably one of the most challenging things that I'm addressing in research and publications, presentations, is noting that, I've lived experience as a caregiver, and my mother still to this day wonders why and how she got it, but it's certainly no fault of hers.
And I would agree with you, Diana. I see the same thing in the pediatric lens, that stigma carries through into our children, and they pick up that from their families. And most of our kids who we see in our program have parents with type 2 diabetes. So I think that stigma is quite strong. Um, and I think I was going to say the same thing for our youth with type 2 diabetes. I think our youth with type 1 diabetes, the big misconception I think they see is that they have to give up so much of their life. And I think where we are at in the current state of care is there's so many different tools that are available in order to manage different ways of eating, manage different types of activity. And I'd love to just put a plug in there to be equitable and make sure that people do have an access to whatever tools they need to provide care and make sure they have the best quality of life possible. I know right now different parts of the provinces have different access to different technologies. So I think that's a big gap that I'd love to see being addressed in Canada in terms of our research that we're doing as well.
I'll go after Jillian.
Yeah, I think it's really important to understand that you can live a really good life with diabetes. I think it's also really important to understand that it's a lot of work and you need a lot of support from everyone in your life and from the technology. And the technology really is game changing. So access is super important. So, then people with diabetes can make the contributions that they should be making to the world, whatever they might be, in whatever way they were destined to. So, yeah, thank you.
I'd agree with Jillian and build on that and say that I think it's okay to say that diabetes is a lot of work, and sometimes you do have to give up a lot of yourself, your mental capacity, your energy, your time, but it's an and equation, not an or. You have to make some sacrifices, and there's resources out there, and there's ways to ask for help, and there's people that are willing to help, and there's people that are asking questions and looking for you to help them as well. And I think that the way that we can combat that type of stigma or misconception is understanding that diabetes is the beginning of a sentence, not the end. So that's why I tell people, like, diabetes is the least interesting thing about me. It's one variable. It's not the end of my sentence. It's just one ingredient of the recipe, and we should treat it as such. Sometimes that ingredient, we put a little bit too much of it and it tastes overwhelming and overpowering, but other times it's just right. It's just one part.
Thank you for that. All four of you, those were excellent answers and really great insight for the participants on the call. I'll wrap up with just one last question that I think came in at the end of speaking about the exercise studies. And Jan, I was hoping you could speak to whether you have noted or others have noted any differences in Indigenous females for either within type 1 diabetes for exercise or more broadly within type 1 diabetes.
That's really outside of my area of expertise. Unfortunately, I can't really comment on that. I do know that within type 1 diabetes, the sample size is quite small, so I don't think we've actually had any efforts made yet to make those comparisons. And it would be a challenging study for which to recruit, but one that definitely should be done. In my case, I would have to sell it as an exercise study, so we'd have to be looking at something exercise related. But I wouldn't be surprised if there is some work going on right now in that area. And especially, I'm just thinking of people that I know who do brilliant work in type 2 diabetes and exercise. I think that there might I don't want to speak too soon. Let's just say I'm hopeful, knowing the people that I know, that there might be something along those lines that's underway right now.
Let's check in the chat. Thanks for speaking to that. I'm just checking the chat here to see if it's more questions, but it looks like it's discussion and many thanks all around for this panel. And I did want to take, it's related to that question. We actually currently have an initiative open right now focused on health equity grants, which is really exciting, looking at the diversity of our population in Canada, and diabetes research focused on the diversity of population, which is exciting. So it'll be interesting to see what, after it goes through scientific review, what Diabetes Canada is funding coming out of that. But since we're at time and it is 4 o'clock Eastern, I wanted to thank you so much to the panelists for joining us today to share your work and to answer questions from our attendees. I want to express my deepest gratitude once more to our donors whose generosity fuels our mission, to our vibrant diabetes community for their unwavering support, and to each and every one of you for your dedication and engagement. It's through your collective efforts that we're able to propel our mission forward and make meaningful strides in research towards a world free of the effects of diabetes. Your contributions are invaluable, so thank you for being the driving force behind our endeavors. And until we meet again, thank you and stay well. Let's keep working together towards ending diabetes.